Racial and ethnic minorities like Hispanic Americans, African Americans, and Asian Americans are more likely to be affected by diabetes and its complications. How can these disparities best be addressed, and what should be done to improve the health outcomes for at-risk communities? We are going to find out in this panel. Karen Kometic is Group Vice President of Health Outcomes at the American Medical Association. Paul Baker is Senior Director for Programs with the National Alliance for Hispanic Health. Celeste James is Director of Community Health Initiatives at Kaiser Permanente of the Mid-Atlantic States. Kenneth Thorpe is Chairman for the Partnership to Fight Chronic Diseases. And Barbara Linder is Program Director of the National Institute of Diabetes, Digestive, and Kidney Diseases. Joining them for this conversation is our the Hills Healthcare reporter, Sarah Ferris. Sarah, I'll take it over to you.
Well, thank you again to everyone for joining us this morning. We're going to dive right in now to talk about the types of groups that are most at risk for developing diabetes, and as well as the communities that are the most underserved in terms of outreach and prevention. So we have a star-studded lineup this morning. Dr. Linder, let's dive right in and let's talk about, in your experience, what disparities do you see in your research and in your experience, and why do you think that certain groups are disproportionately affected?
So we know from research that the NIH and the CDC have supported that certain racial and ethnic groups are disproportionately affected by type 2 diabetes. In particular, African Americans, Hispanic Americans, and Asian Americans are almost twice as likely as non-Hispanic whites to develop type 2 diabetes. And the rates of type 2 diabetes among American Indians are even higher. And I'd like to mention that although we've traditionally thought of type 2 diabetes as a disease of older adults, over the past decade, there's been an emergence and an alarming increase in type 2 diabetes among young people. And we see these same disparities, so that minority youth are much more likely to develop type 2 diabetes. And their diabetes is often not well controlled. In addition to the racial and ethnic disparities, we also see health disparities based on income and on education. And these factors may contribute to the development of type 2 diabetes, since we know that unhealthy lifestyles are associated with type 2 diabetes. So people who are poor may not have access to healthy foods or live in places where there are safe places to engage in physical activity. People who are not well educated may have poor math skills and may not be able to engage in good self-care practices that are required. Type 2 diabetes is a chronic and complicated disease to take care of, so it can be difficult if you don't have math skills. And we also know that genetic factors influence type 2 diabetes. For example, it's recently been reported that Asian Americans will develop type 2 diabetes at a lower body mass index than other groups. And so disparities exist here because physicians may not be aware of this and may not screen Asian Americans, and therefore they may go undiagnosed and uncared for. So it's a multifactorial disease, and therefore there are many factors that contribute to the health disparities.
How long have we known about the research that points to these certain groups? Was there a point where the data started to crystallize and the U.S. began to realize where the efforts need to be directed? Has this been a slow and gradual effort?
I think it's been a slow and gradual effort. I don't think that there's been a single point in time. We collect statistics, on an ongoing basis, and this has just become clear over time.
Right. So Paul, your group focuses specifically on the Hispanic community, and I want to hear from you this morning a bit more about how you see this disease affecting people who, as we've heard, are more likely to be to experience this disease and to struggle with healthcare access. And can you talk a bit about what the biggest challenges are, in whether it's outreach or whether it's access to care, and how you're addressing those?
Right. Well, as we know, Hispanics are twice as likely to be diagnosed as non-Hispanic whites with diabetes. So just, there are a lot of disparities already built in here. And I wish that there was, a great solution to this problem. But unfortunately, there is no wonderful one-size-fits-all model program intervention out there that can really address this in one fell swoop. So, what we have found is that we really need a variety of culturally proficient, bilingual programs, interventions, tools to help folks access care quickly, easily, and that really address a lot of the barriers that we see when we look at access to care. Diabetes as well as many other chronic diseases, but I'm talking about transportation or child care issues, getting to services. I'm talking about different cultural factors that are built in that prevent folks maybe from thinking about this as a chronic disease that they can do something about. Varying levels of English literacy, perhaps mixed immigration status households. There's sometimes some fear with people and mistrust of government programs and services. So what we need are a variety of interventions, programs that address everyone's needs out there and can help connect them to the services that they need.
And is there how much of that is a community health element? Are there any successful examples of these types of programs that you're already seeing? Are there things that you would like to see in an ideal version of this, where there's the partnership between people on the ground and government programs and non-governmental organizations?
Yeah, I think we all, really need to come together and make sure that we're not duplicating our efforts. We really need to make sure that our community programs and other stakeholders are working with the state health departments, for example, and because they're tasked with addressing this as well. The connections between those health departments and the communities has not always historically been the best or the easiest, so we have to work at, improving those relationships too, and not just going into a community and saying, we know what to do, here's what you need to do to cure diabetes, and assuming that they're going to implement that and then take off and leave and never come back. We need to go in and engage the people in the community leaders. They know what their the problems are and the solutions are. And so, we've done many multiple multi-site, multi-year diabetes interventions around the country, working hand in hand with Hispanic community-based organizations. And I think the one thing that we know for sure is every time you go in, you have to have a good expectation that you'll need to be flexible, because no matter what intervention you're trying to implement, no matter what kind of program or approach you're taking, you're going to have to tweak it along the way. And that's what we found is sometimes a big problem with some interventions, evidence-based, designed for Hispanics, but there's no flexibility. We did a great program in Watsonville, California, which is a large migrant seasonal farm worker community there. And we went in thinking that we had a great intervention that was designed for Latinos, and there were just too many workshops. The community was too transient, following jobs. So we had to go back to the intervention creator, convince them to condense the material, reduce the number of workshops. That was a big help. We had to identify a translator for those people that only spoke Mixtec, which is an indigenous Mexican language. We had really no clue that that was what we were going to come up against. So I guess my point is that, whatever the solution is, we have to be flexible, and we have to realize that every community is a little bit unique. Mm-hmm.
And Celeste, I'd like to turn to with your extensive on-the-ground experience. Talk to us about the community health interventions that you have seen and managed over the years, and what you think, how you think you can help successfully launch these types of programs, and what works.
Sure. So Kaiser Permanente is the nation's leading integrated healthcare delivery system. And so we provide quality, comprehensive, coordinated care in our medical centers across the country. And so we start by providing the best possible treatments for diabetes within our medical centers and our hospitals around the country, and providing care as conveniently as possible. So in person, online, video conferencing, et cetera. But we know that we're not doing enough healthcare providers if we focus only in our medical centers. So on the ground in communities across the country for a number of years, we've been leading initiatives that are multi-sector. We just talked about how everybody needs to be involved in these solutions. And these are multi-sector in that it's healthcare, it's the funding community, it is oftentimes the school communities. We are also working with, in some cases, housing and development, all of these organizations that work on social determinants of health, essentially. Because we believe that if we are to really address this problem in a significant way, then we have to change not only behavior, but we have to change the systems and the environments that typically drive health. On the ground, we've been looking for a number of years at things such as access to healthy food in neighborhoods, through farmers markets, urban farms, healthy corner stores. We've been funding organizations that are very interested in bringing healthy foods into neighborhoods and are doing it in a major way. For example, DC Central Kitchen, which is an organization here in the district, we've been funding them for several years now to do something called Healthy Corners. And Healthy Corners is basically just that. It's bringing healthy, farm-fresh fruits and vegetables into food deserts, into the neighborhoods that provide, that don't typically provide healthy foods, and ensuring that the stores are equipped to deal with healthy foods. So the storage and the refrigeration and the promotion. We also have focused our programs on, or focused our funding to a large extent, our grant funding on programs that provide farmers markets in neighborhoods that don't have regular grocery stores, what we call food deserts. Those farmers markets we also provide farmers markets at our own medical centers to make it easy for people to pick up fruits and vegetables on their way out of their doctor's visits. So we've been looking at a number of ways to address food access, access to physical activity, helping to develop trails and parks and playgrounds, and to make sure that those things are accessible in the neighborhoods where, as we mentioned, we have a number of people who don't have regular access to those kinds of important assets.
Sure. So I want to get a bit to the policy side and where the federal government has come in on this. And Karen, you've talked about the unprecedented opportunity to prevent diabetes, type 2 diabetes in particular. And I'm hoping you can tell us a bit about the diabetes prevention program and what the U.S. has learned in this study.
Happy to. Thank you, Sarah. We know there are about 30 million adults today who have type 2 diabetes. In addition, there are about 86 million adults in the U.S. who have pre-diabetes, so high blood glucose, not high enough to be diagnosed as type 2 diabetes, but still in a very important risk range. But the good news is that we have this evidence-based National Diabetes Prevention Program. So this is a program that was actually studied back in 2002 by NIH, who found that individuals who receive this intervention, which is lifestyle coaching, things like how to evaluate a menu when you go out to eat, modest exercise, that compared to placebo, those individuals saw a 57% reduction in risk of progressing to type 2 diabetes. And it was even 71% for those 65 and older. So those are pretty impressive results if you think about preventing the progression to type 2 diabetes. And so the wonderful news that just happened recently last month is that CMS issued a final rule which says that beginning in January 2018, Medicare will cover this diabetes prevention program for Medicare beneficiaries. They're starting by covering it for in-person programs. They're offered in many places, such as YMCAs, such as Kaiser Permanente healthcare systems, faith-based organizations, are all offering this diabetes prevention program. And beginning January of 2018, it will be covered by Medicare. We think at the AMA, along with the CDC, that we clearly need to have this program available widely to meet all populations. And it needs to be in different forms, not just in person, but virtual, online programs. These are also showing strong results in helping people not progress to type 2 diabetes through modest weight loss. I often say, Sarah, my mother is someone who will want to go to an in-person class. She will go to the YMCA. She will thrive in that environment and learn in a group setting. My brother, he'll want to have that experience online. So to reach 86 million adults who have prediabetes with this evidence-based program, we need to have a variety of options, as the previous speakers have said. But the good news is that we're getting coverage of it by Medicare and a growing number of private plans.
And I want to open up the question to everybody on the panel about what this final rule and what the government's saying of, we have faith in this program, we think this can make a difference. How much of this, how important do you think this is? And is this a watershed moment? Is this something where it will be a great first step? How do you all see this announcement?
Well, I think it's critically important for a couple of reasons. One is that it's precedent setting in that Medicare has usually focused on just paying bills. And this is a whole different type of benefit that's put into place that really is focusing on proactively preventing the progression of disease. So I think our big challenge with this is really making sure on the implementation side that we get the participation rates as high as possible. And so I think to Karen's point that we'll speak to having this new opportunity available in all types of different forms, whether it's online, whether it's in person, community-based settings, and so on. So I think the rollout of this is going to be critical, and we need to do everything we can. I know the AMA has been very active in this and trying to educate their members about the availability of this resource, but I think that that's going to be critical. I think we need to link that, though, to not only the prevention, but the engagement and management of patients that have diabetes. So I think there's a wonderful opportunity going forward in discussing sort of Health Reform 2.0 about how do you build evidence-based care coordination into traditional fee-for-service Medicare. And I think that's going to be critically important because we've been focusing on diabetes, but if you look at this population that's diabetic, the vast, vast majority of them have 4 or 5 additional chronic healthcare conditions. So if we're really going to do a good job of working with diabetic patients, we really have to have an orientation that's focused on whole person care. So if we're not managing the depression, we're not going to manage the underlying blood sugar levels. So I think just recognizing that these are patients that not just have diabetes, but they're very clinically complicated and may have a whole range of other chronic conditions that simultaneously need to be managed.
Right, and speaking of all the rising healthcare costs that we've been hearing about this morning, the care of of patients with chronic conditions is skyrocketing, and we see that. And does CMS and does CDC and even to an extent NIH have the tools to do this? What does the federal government need to do to make sure that this goes smoothly?
Well, they need to build evidence-based care coordination into the program. And a statistic that I don't think it's enough to play is that if you look since 1990, 80 to 90% of the growth in Medicare spending is due to rising rates of chronic disease prevalence, most of it potentially preventable. So, we really can't have an effective cost containment discussion without dealing with preventing the growth in chronic disease, but also managing it. I mean, 86% of what we spend on healthcare is linked to chronically ill patients. So if we're not doing a better job of keeping these patients healthy, keeping them out of the hospital, making primary care affordable, having appropriate medication therapy management, and really working with these patients at whole person care, that's the key to saving money, and that's the key to improving the quality of healthcare.
Right, right. And Dr. Linder, I'd love to hear more from you about how this research is translating into sort of these on-the-ground efforts and these partnerships with the other organizations that we've heard.
Right, well, just to follow up on this, we have a program now that we've initiated to try to focus some research grants into the primary care setting. So we have a long history of supporting community-based research as an outgrowth of the DPP, but there is this tremendous need to understand how to leverage or have innovation within existing healthcare settings for patients with type 2 diabetes. And so we're giving research grants for people to study, not bringing in a researcher to do an intervention, but how to understand how to use the personnel that are present within a practice and have innovative models like group settings or multidisciplinary approaches to help people with chronic disease deal with their illness.
Mm-hmm. And Karen, if you could talk about how the providers fit into this and what the challenges are in kind of linking up this care and linking, obviously everyone has the same motivations here, but how does this translate to on the ground with a million other things going on?
Sure. You know, when we say the number 86 million adults have type 2 diabetes, it can sort of put you on a deer in the headlights. What do I do with that large number, right? So when we talk to physicians and care team members, we talk about the fact that that means a third of their practice. If it's a primary care practice, about a third of their patients likely have prediabetes. And when we say that, you know, physicians and care team members say, we know that. What can we do? We typically have 15 minutes to interact with our patients. As Ken said, they have multiple conditions quite often, and we need to emphasize and prioritize our time. And so when we give them this information, when we say, we know that, what we want you to do, physician and care teams, is to take the blood test, talk to individuals about their risk, and then refer them out to a diabetes prevention program. They are delighted to hear that. They haven't been aware of the evidence behind that and the fact that they can now refer patients to these programs in their communities. So it's been received very positively by the physician and care team communities that we've been talking to. The very next question, though, that physicians will ask us is, okay, Karen, it's evidence-based, I've got the programs in my community or they're online, but is it covered for my patients? And it's very difficult to say to a physician, well, it's covered for that population, but not this population. You know, physicians don't think that way. They think about their patient population. And so now we are saying it is covered by Medicare starting January 2018. It is covered by other large private plans in different states. And so we give them that information. But the more we can all work together so that employers are putting it in their health benefit packages, private plans are covering it, we have enough of the DPPs in all communities, in all varieties, in person and online, then the message to the physicians and the care teams is an easier one to say, all patients, pre-diabetes, refer, it's covered.
And Paul and Celeste, I was just going to say, maybe you could talk about how to get the patient in the door when there are some of these confusing signals about what's covered and what's not, and maybe it's difficult to understand some of the instructions that you hear from your doctor. How do you make sure that that patient can go in and follow up on the care?
Sure.
Well, I was just going to say that's why a program like the ACA is so important, and why what the ACA turns into is so important, because it expands that access to care that a lot of communities would not, otherwise not have. So, the DPP is a wonderful program. We have to make sure that it's available to as many people as possible, and at times that aren't traditional, because a lot of people are working multiple jobs. They can't access it during the day. They'll need to be accessed it online. A lot of folks in the Latino community aren't necessarily have great access to the internet. So what does that mean? Where do they access it? It has to be non-traditional hours, things like that. The other thing that we really need to do, I think, is improve education. We do a lot of surveys through our research institute, USC Keck School of Medicine. And the latest one we did on diabetes to try to get a pulse on the knowledge and attitudes of Hispanics. There's broad understanding about diabetes, awareness about the causes, the symptoms, but when you drill down lower about prevention and management is where the education is really lacking. And so that's either because their provider is not helping them understand that. I mean, I think 3% cited managing blood glucose levels as a key way to manage diabetes in this survey. So either the providers aren't communicating that, or they don't have access to a provider to be able to tell them that kind of information. So that's pretty key.
So I want to add to that to say two things. One, we have to do a much better job of helping our physicians to screen not only for the obvious risks in the medical center, in our medical and clinical settings, but also the risks in our neighborhoods. So asking questions about access to healthy foods, access to food in general, so food security, access to places to walk and to move people's bodies. I think those are important questions that physicians don't always ask, or aren't prepared to ask, or don't have the time to ask, or think they don't have the time to ask. So I think it's important for us to ensure that we equip our physicians to be able to ask those questions in the medical setting. The other thing is that we talk about education, and I think there's education with regard to health literacy, and navigating the healthcare system, but I think there's also the basic education, and we alluded to that on the panel, is that there is a pretty direct correlation between education and income and health. And so if we don't address, again, at a very upstream level, the core causes of ill health, such as just the inability of people to have an income, to have livable wage, and to be able to take care of themselves in the right way, we're going to continue to have these problems. So no matter what we do in our healthcare settings, if we don't address this as a social issue and an economic issue, it's going to be very, very difficult to fully address this.
And on the insurance provisions, we've heard about Medicare taking this next step. There are some private insurers, from what I understand, that are also trying to make this to offer this benefit and to help advance these types of care models. What do you see as the next 5-10 years, even beyond that, in terms of private insurers trying to offer this and making sure that diabetes care is more widespread?
So, well, we prioritize our diabetes care, and we provide within our medical settings free, without extra charge to the benefits for our members. We provide wellness coaches. We provide one-on-one consultation with diabetic consultants. We also make sure that our physicians are talking to those wellness coaches and to those dietitians. We provide online healthcare classes and health education, also in-person healthcare classes. So those are things that we try to ensure are available and so that they're affordable for anybody who needs them. We also have what we call our charitable healthcare programs, where we have right here in this region about 9,200 members who are part of that program, and they receive Kaiser Permanente health care at low or no cost. And that is because, again, we want to be able to make health care as affordable as possible. And we have, through our community benefit programs, we have programs that enable low-income members to take part in our healthcare system and receive excellent health care, and also medical financial assistance. So where there is need to help with co-pays and premiums and so forth, that we also believe helps to make it more affordable. So there are ways to do it.
So if I could just add that Medicare is covering this not just because it's an evidence-based program that works, but because the analyses have shown that in the long run, this will be cost saving, because preventing diabetes, which costs us $245 billion a year, will decrease those costs, because you don't have to take care of the people for their diabetes, and they don't develop the disabling complications that present not just a burden for the individual, but for the healthcare system. So hopefully these studies that have shown that these programs are actually health savings will spill over into the private sector as well.
And I'm wondering what you and others are hoping to see out of this, out of the Medicare rule, and when you think you can start looking back and looking at the data and saying, will this work? Should we expand this? Should private insurers take note of this? What will you be looking for out of this?
I think in the final rule, what's going to be important, and we have to remember, is that it's now a Medicare covered benefit. And Medicare Advantage is 30% of the Medicare program. So you have a whole host of private health insurance plans that when they go through their bidding process, it's going to have to include the diabetes prevention program as part of that underlying bid, because it's a Medicare covered service. So I think that this will actually move out pretty quickly. And on the question about the future on these health plans, Celeste has been raising this, I think, throughout the session. I think what's going to be important going forward is, as we look at the evidence of plans like in Vermont with their community health teams, where Medicare saved $2 for every dollar they invested. What we learned from that is that the savings really came because you're integrating health and social services. And that integration of social service programs and existing health programs and public health programs really go to the point of where can we get to the issues around avoidable mortality, morbidity, and so on. It really is the underlying social determinant. So if we're really going to be effective downstream on the cost containment piece, as I mentioned before, this issue of really developing evidence-based care coordination that does integrate social and healthcare services, I think, is the future.
Sure. I did want to get back to the role of the ACA. As Paul mentioned, the threat of healthcare reform being erased in full or in part. What could be, obviously there are high stakes here in terms of the cost of this disease and other chronic diseases, and preventative care maybe not being covered as an essential benefit. What are some of the risks here, and what do you think that progress can be going backwards? affected?
I think one of the main risks is that if you look at the data in the employer market, 10 years ago, 4% of the employed population was in a high deductible plan. Today, 25% are in high deductible plans. So if you sort of look at the issue around getting access to primary care services, access to appropriate medications, if we're simply going to rely on increasing deductibles to save money, I think for the most part that's not the way to go. I mean, if we really are interested in improving quality and saving money, we need to go to the heart of the problem, which is preventing chronic disease prevalence increases and building a delivery model that really is effective in working with and engaging patients to keep them healthy. Because that's where all the money is. As I said, mentioned, 86% of it is linked to these patients. And simply charging them a $5,000 or $10,000 deductible is penny wise and pound foolish. It's just going to discourage people seeking appropriate care.
Sarah, if I could add, the other great thing about this new coverage of the diabetes prevention program by Medicare is not only is it covered for the year-long program, so this is a year-long program with evidence-based curriculum, as I mentioned, but also for those who experience the modest weight loss, the 5% weight loss, the coverage continues for maintenance after that, which is very important. And it's so exciting to see that we are investing in helping someone achieve a goal that will prevent a chronic disease and helping them maintain that preventative state. The other things that are part of this that I think are welcoming to most is the way that the diabetes prevention program providers, be it Kaiser, the YMCA, other programs, are paid is pay for performance. So the payment from the government to a diabetes prevention provider program is based on sessions attended by an individual, weight loss achieved. So it's outcome-based for all populations. So there are so many pieces of this that I think speak to what many have been saying we need to see in our healthcare system. And here we're seeing it for prevention.
And what do you think are some of the biggest barriers to getting to that point? Just in terms of outreach or prevention or even disease management, getting to this point? What are some of the biggest hurdles?
For me, it's spread, right? So we have the knowledge, we know it's evidence-based, we know the programs are there, and now it's covered. You know, how do we as a nation now turn this on? Turn this on. You know, we're doing what we can at the AMA to reach all physicians and care teams to do their part. What can other private plans do? As I mentioned, many are covering this. Anthem of Colorado, Anthem of California, different United plans. There's a long list and you can see that online. But we need all private plans. We will need Medicare plans to cover it. We need employers to speak up, those who are self-insured to cover it, and those who work with a health plan to say, we would like this in our health benefit. We at the AMA, we put it in our health benefit. So if we all do our piece, perhaps we can see this spread faster than we have seen other preventive programs in the past.
Sure. And Paul, I'd be curious, the cost of drugs to help manage the disease, how do you see that as an issue, and how do you see that, how much of a barrier is that for people who go to the doctor and who learn of their diagnosis and realize that they have to deal with this disease in their life now?
It's a huge barrier. I mean, I think, you know, one of the things that we do at the National Alliance for Hispanic Health is try to connect folks with low-cost providers, sliding fee scale services, because, you know, it's cost prohibitive to really treat and manage diabetes in many ways. And so that's why, you know, the focus really does need to be on prevention before we get into that disease. And, you know, I think, you know, making sure that people are outreached to and brought into, and how do you turn it on, I think was interesting because a lot of it has to do with messaging. You know, I think the Latino culture especially is very family oriented. So the adults may, you know, be focused on the children, they're not focused so much on themselves. But if you switch the message to say, you need to take care of yourself and your health for your children, to be there for your kids, that can be an effective way to sort of, you know, get people to listen and understand why this is so critical. So it takes different messages for different populations in different settings.
Celeste or Dr. Linder, I'd like to hear about why you're optimistic about the future of this, because this is definitely, the conversation this morning has been optimistic and hopeful. And tell me more about why you think that way.
Well, I mean, I think having conversations like this gives us hope, because we're getting better understanding about the disease. We're getting much better understanding about what the risk factors are and who's at most risk. And so if we can, again, bring all parties together so that it's not just a healthcare problem and therefore not just a healthcare solution, I'm very hopeful that, that down the road we can see some real improvement in the rates of diabetes. So I think that, again, just by having these conversations and really getting to a better understanding about the disease is very helpful.
Well, I also think that the National Diabetes Program shows that research works, that NIH can do research sort of in the rarefied academic atmosphere, prove something works, and then it gets translated. So out of the original DPP program came the National Diabetes Education Program to develop a lot of educational materials for patients and families and practitioners that are freely available in many languages, directed at many different reading levels. Once we had the results of the DPP, we started funding research to try to figure out how to do it in the real world. NIH funded the first pilot in the Y, showed that worked, then the CDC took it over. So, I mean, the research enterprise works, and now you've gotten to a point where you've created a national program that is also evidence-based and is going to be covered. So there is optimistic that the research enterprise really can create real meaningful, results, not just a paper, in a medical journal.
Do you think there is a gap in research that does still exist in certain areas? If you could design an ideal study, if you had all the resources, is there a part that you say that we really want to understand this better and this is a new area for us?
Well, I think there are many gaps. I mean, we've been talking all morning here about how to overcome the barriers, to adopting good prevention, approaches. We also have to deal with better treatment for people who, do develop diabetes. And we have a very large clinical trial that we've just started to compare the approved medications for type 2 diabetes to understand which combinations, might work best. That study, the GRADE study, is recruiting 5,000 participants. Nearly half will come from racial and ethnic minority groups. And we're hoping that this study will begin us down a path of personalized medicine, being able to understand which drugs are right for which people or which groups of people. So there are many gaps that need, to be filled.
Mm-hmm. And Karen, do you see gaps in terms of provider knowledge or provider outreach and being able to say, these are the groups we want to reach, we're struggling to do this? What gaps do you think exist there?
I think one thing that we all can keep working on is building that clinic to community linkage. Mm-hmm. We talk a lot about that. We know that health is not needing to all be medicalized, right? We want to get out into the community where the resources exist. So, we need to better understand. So if a physician group is referring someone to a diabetes prevention program in the community, how do we make that seamless? How do we make that bi-directional so everyone is supporting the patient with their approval and supporting them on this journey? So we work with some healthcare systems who are querying their electronic health record system, right? How do we use that technology to say we can identify individuals in a population who have prediabetes? Could we use the electronic health record system if it was compatible with systems out there in the clinic, in the community, to refer individuals, to get some pieces of information back so when a patient comes back into the office and says, I am in the diabetes prevention program, I'm 4 months in, and then they receive another blood test, there's that mutual support of the patient, right? This all needs to focus around the patient. And let's think about how do we build these linkages? Today it's referring to a diabetes prevention program. Tomorrow that same program could be looking at helping someone control their blood pressure, right? Mm-hmm. So we're beginning to build this incredible network covered by Medicare. Sort of like shame on us, right? If we can't figure out how to bring all pieces together.
And Dr. Thorpe, I was actually going to ask how you see this model as being applied to other chronic care, other chronic diseases, and how far-reaching this model could possibly be in the future.
Well, I think it has broad implications because, I mean, the history of it, it rose up through the diabetes division in CDC, but the reality is it's really the chronic disease prevention program because it affects weight, diet, exercise, and nutrition. So it not only reduces the incidence of diabetes, but it affects blood pressure, lipid levels, underlying depression, pulmonary disease, and so on. So it has broad-ranging implications for a range of chronic conditions. So, you know, I would hope that we'd find ways to scale this as fast as possible. I'm kind of optimistic that as we sort of get this integrated in the Medicare program and get it linked into Medicare Advantage plans, they're going to have to find a platform to make it available to their members, and I mean that'll flow over to the commercial side as well. On the research side, I hope, and I'm a little bit optimistic here, that we've moved from a pilot mentality to an implementation mentality. So I see this with the DPP. We've had this data for a decade, more than a decade, that this thing works, it saves money, and improves outcomes. We have similar data in terms of interdisciplinary primary care teams, and sort of what are the characteristics of those care teams that really make them work effectively. So I'm hoping that, you know, I sort of have pilot fatigue. We're not one pilot away from a miracle here. We have a lot of data and research that we know what works and why it works, and I'm hoping that we've sort of turned the corner and focus on implementation, still doing research in areas where we have gaps, but we're really now in an implementation mode, using, I think, Medicare as an engine to really make this type of system transformation that needs to occur.
Well, thank you so much for wrapping us up. That was a great way to cap this off. And thank you again to everyone for joining us, and thank you to our panelists.
Thank you.